Good evening, everyone. I'd like to acknowledge the local custodians of the land in which we meet on this evening and honour elders past, present and emerging. I'm Melissa Wilkinson from the education team at the PHN, and I'm sitting on Dark and Jung land at beautiful Avoca Beach. Welcome, everybody. Thank you for being with us here tonight. It's a really important topic and really appreciate your time with us this evening. Just some housekeeping. There will be a poll at the end of the webinar and a survey will crop up. This is to help us plan future education events, so I strongly encourage you to please complete that. It only takes a couple of minutes and that data is really valuable to us. We're also being recorded, so you'll be able to access this at the end with a copy of the presentation, the slides, in our education library via the website. Also, we will allow a little bit of time for questions at the end, so if anyone has any questions, could you please pop those into the questions box and we'll get to those later. I'll now hand you over to Dr. Georgia Page. Thank you, Georgia, for being with us once again. Really appreciate it. And Georgia is a GP at Your Family Doctors at Erina and also our clinical lead for the vertical integration program. So I'll hand over to you, Georgia. Thank you.
Thank you, Melissa, and welcome everyone. And yes, so for those that don't know me, I'm a GP at Your Family Doctors at Erina, and I've also been a sexual assault examiner at Gosford Hospital for the last 15 years. So as as GPs, the disclosure of sexual assault is unfortunately not uncommon, but with appropriate care and advice, we can help aid our patients' recovery from their traumatic experiences. So to tell us more about the sexual assault services on the Central Coast and the medical, forensic and psychosocial care received by victims of sexual assault, I'd like to introduce our expert speakers. So first of all, we have Amanda Baxter, who we're very lucky to have in our service as a sexual assault nurse examiner and clinical nurse specialist. And also we have Dr. Vicky Chase, who wears many hats, but in particular she's a staff specialist for violence, abuse and neglect, and is the medical lead for the sexual assault services on the Central Coast as well. So welcome Amanda and Vicky, and I'll hand over to you guys. Thanks.
Thank you. All right. So our topic this evening is the sexual assault services, in particular on the Central Coast. So it's giving you an understanding of how our service works. We talk a little bit about disclosures and also how to refer into the service and what follow-up care that we can provide to our patients and clients of the Central Coast. So the overview, as I said, is of the sexual assault service on the Central Coast. We are based in Gosford and we respond to children, young people and adults who have been sexually assaulted, and we also support families, carers and others. This evening we're going to outline the medical care follow-up recommendations. And that's the acute and non-acute crisis responses, the medical forensic care and what that looks like, and the management and ongoing interventions and support to patients and clients. So overview of the sexual assault service is that it is located in Gosford, and I'm just going to literally move that over, sorry, just so I can see my full screen. So it's located in the centre CBD of Gosford, and we work out of Gosford ED, and so we don't work out of Wyong ED. So that's just really important to note if you are referring clients to the sexual assault service emergency departments, that it's directed to send them to Gosford. And we provide a 24-hour integrated psychosocial, medical and forensic crisis response to both adults and children. And the key sexual assault service model that we give for our clients is a 24-hour service, a medical and forensic service, which is a 24-hour service as well, and follow-up care, and ongoing trauma-informed counselling and other therapeutic interventions. We do system advocacy, which is legislation, policy and practices, court preparation and support as an expert witness, and professional consultation and training, which we go through ECAV to attend our training, and community engagement, education and prevention. So barriers to disclosure for patients and clients' perspective is something that we think about relatively often in terms of, why did that child not say anything? Why did that adult not say anything sooner? And it's the ongoing risk and safety that they feel, their relationship to the perpetrator. So if it is a child, if it's a father, a mother, an uncle, an auntie, the fear of the perpetrator can prevent the adult, adolescent, child seeking help and reporting to police. The timing of the disclosure is basically around all of those. So if there's risk, if there's safety, they will protect themselves first before asking for help anywhere else. So there's that delayed response. And then there might be the concerns that the parent or guardian have about another member of the community or somebody within their family. So there's no specific disclosure by the child or adolescent, but something raised by the parent or guardian. And a lot, we see this in the adult world, is if they don't have any injuries, the sexual assault wasn't observed, it wasn't a party environment where somebody can say, that person has gone off with that person, they're less likely to make that disclosure sooner. So if there is a child that discloses, that comes into your GP practices, what we recommend is that you contact the local sexual assault service at Gosford. The social worker will be the one to be on intake, and or if it's after hours. So our service is 8:30 to 5, and then from that time it's an after hours response. If it's for the on-call social worker, when you contact the sexual assault service, it'll give you information as to the time of day it is, if they're there or they're not there, if you need to contact the emergency department. And the information that's required from the social worker is obviously the name of the child, the date of birth, the date and time that the assault occurred, if it's known, and the type of assault. So is it a penile, vaginal, oral, or anal assault? The medical information is just as important. So when they arrive in the ED, if there was intoxication, if there's an intellectual disability, acute mental health concerns, reduced consciousness, physical trauma, a history of a recent sexual assault or penetration with an object, recent head injury, and or unexplained genital or anal bleeding. Any contact details that are accompanying the referral that you're making. So if the JCPRP team is involved, if the police are involved, or the JRU. And of course, our mandatory obligation rights is to make that child protection report as soon as possible. So that starts that response by JCPRP and DCJ. And it can be as soon as you made that report, it goes straight through to the appropriate body. So by the time that child has hit the ED and is asking for a medical forensic response with the family, most of those details are already given and the appropriate people are on hand, and it doesn't delay in any way, shape or form. A clear disclosure by an adult that attends your GP is relatively the same process. So for an adult, it's obviously that the adult needs to provide consent for you to contact the sexual assault service and provide the details. The sexual assault service does preference that the client or patient of your service contacts the sexual assault service directly, but you can advocate on your patient or client's behalf. And again, if it's a recent sexual assault within the 7-day period is one of the questions that the social worker will ask, and just that general information again of the name, date of birth, type of assault, and then any medical information. So all of these things will help when the patient presents to the ED, because they may require medical follow-up first before forensics, and medical care is always given before forensic medical examinations are attended. And if there's any contacts with police. So as a GP, you're not obligated for an adult to report that to police. That is up to the client to make that decision of whether police are involved. And the emergency department sexual assault service will talk the patient or client through that process of if they're wanting to involve police or not when they attend that medical and medical forensic response. So when we look at the sexual assault crisis response presentations to ED, this is the general outlay of time frame. So if it's a recent sexual assault in the past 7 days and the patient presents to the emergency department, it is a 24-hour integrated psychosocial, medical and medical forensic response that's offered. If the sexual assault is in the past 7 to 14 days, it's a business hours response, so that's at 8:30 to 5 of an integrated psychosocial and medical response. So generally speaking, they're outside of that forensic time frame after the 7 days. And we're doing STI screening, injury, care or treatment. Sexual assault of an under 16-year-old of more than 14 days is a business hours integrated psychosocial and medical response, and generally speaking the forensics is if there's any relevance. So we do record if they present to the emergency department in what we call a medical forensic examination record, and that can be used as part of the forensic evidence gathering. Past sexual assault, so if it's more than 14 days where the presenting issue is sexual assault, a 24-hour psychosocial response only is provided, and then the medical care by the forensic examiner is done during the business hours of the following day, where we will contact the patient or client that you have referred in. And past sexual assaults of an Aboriginal Torres Strait Islander person where the presenting issue is sexual assault is a 24-hour psychosocial response only when presented to the ED. And then again, they'll have a medical response the following day in business hours with the sexual assault examiner, and it's offered to them. So we also have a violence, abuse and neglect outpatients department, which in particular is focusing on our sexual assault clients, and that can be a recent sexual assault or historical sexual assault where they haven't had any medical follow-up care since the assault. And we are generally doing our STI screening, any injury follow-up and assessment, contraception and counselling service. So if they decide, some people when they first present to the ED decline counselling services, and then when we book in their appointments sort of 1 to 2 weeks after that initial ED, we're always offering that counselling service to them, and we have a counsellor on hand that we can refer them to. So for STI management guidelines for yourselves in that GP practice is to obviously assess the needs, the immediate needs of the patient that's presented in front of you, and any injuries that require treatment. If it's PR or PB bleeding, we recommend referral to the ED. If they advise that they've had a head injury during the assault, we recommend referral to the ED. And assessment for strangulation, so it's asking the question of, was pressure placed upon the neck during the assault? And if the answer to that is yes, then we're also advising to refer that patient to the ED. And that could be just that medical follow-up. So if they're absolutely adamant they don't want a forensic follow-up, they will get a medical follow-up in the ED that is assessing these needs. We offer for STI sexual assault service referral to crisis follow-up counselling and medical examination, and it's again it's their consent that's required in order for that to occur, but we always recommend that you offer it to the patient when they present or they're giving that first disclosure that a sexual assault has occurred. Undertake a pregnancy risk and assessment if it's a female patient, and offer emergency contraception. HIV PEP if indicated, and a 30-day pack can be administered. Firstly, we do a 3 to 5 day pack through the emergency department, and then we refer them on to the sexual health clinic for their 30-day pack. So we recommend that you refer them to the ED. Syphilis and hepatitis B vaccination is offered to anybody who is non-immune or vulnerable to infections. And chlamydia and gonorrhea is at 72 to 120 hours, and also considering other infections, especially if it's an at-risk patient or perpetrator of the community. And the assessment of immediate safety and well-being, including a psychosocial assessment, is also recommended. And these are coming straight from the STI management guidelines, which I've just added to the bottom of that page. If anyone was wanting to look anything up, that gives you a very good guidance on if a patient presents to your service with a sexual assault disclosure. And so medical follow-up care. So again, straight out of the STI guidelines and something that we practice with our sexual assault service. So what we're looking for if they're coming for their 4-week visit, if they haven't already or they're undecided about STIs, we would offer STI screening to them, assessing their psychosocial well-being and further supports, and likely administering their second dose of hepatitis B. 6 weeks, if they haven't had that second dose of Hep B, they'll be coming. They may want assessment again. So basically at every initial contact, it's that psychosocial assessment and well-being and checking in. It may be HIV bloods that they're requiring, or post-HIV PEP assessment if indicated. 12 weeks, as well as checking in on them, HIV, syphilis, and HPV bloods if indicated. You may want to consider Hep C bloods as well if the assault involved injectable drugs, voluntary, and prior to the sexual assault. And then 24 hours is if it's their final dose of their HPV vaccination. And also, again, historical sexual assault where they may not have had any type of STI screening or follow-up is always to flag with them if they're wanting some screening, if they're wanting bloodborne virus serology, contact with police, and again, checking in on them. And they can do that through the sexual assault service as well. So if they come in and it's you know, a while down the track, that they can still present to the sexual assault service and get some medical care and some counselling support. And the counselling support that's offered at Central Coast is a free service. So next is the lovely Vicky, who's going to talk to you about some of the ECAV training that's available. So if the GPs out there are considering sexual assault as a little side hustle, then I would absolutely recommend the ECAV training. So Vicky, are you there?
I am, but I was muted. Sorry about that. Sorry, Amanda, to be a pain. Can I just get you to jump forward to the next slide? I'm just a bit out of order, so I might go forward one, then back one, if that's all right. So thanks, Amanda, for that overview of the sexual assault service and how we manage presentations. As Georgia said at the beginning, I'm a staff specialist with Central Coast Health, and currently I work in a few different areas, but currently working with the violence, abuse and neglect services. So when we look at the medical and forensic workforce with Central Coast Health, we have a very experienced nurse examiner, Amanda, GPs like Georgia that can contribute to the forensic roster, particularly after hours, and then other players are the emergency staff and the paediatricians. So it's a sort of quite a varied workforce that provide a forensic response. So my work as a staff specialist is alongside all of those different specialists. I also provide consultation to a range of different teams within van services. So over on the side of the screen in the boxes, we've got listed a whole range of specialist van services. They're all multidisciplinary teams, and some of them have got sort of fairly confusing names, but they cover such a broad range of different concerns. So our sexual harm and safety teams, family therapy and treatment, partnerships and education, so that involves our domestic violence services and our child protection services, and then we also have out-of-home care, which are the teams that provide support to those children that are in foster care or living in group homes or circumstances like that. So I guess that's the other side of the work that I'm doing. Sorry, Amanda, if we just jump back to the ECAV. So I guess for anyone that's interested in further training opportunities or work in this area, there's a wide range of options. And I guess what we wanted to illustrate tonight was, some of the different pathways where people with an interest can kind of enter and gain experience. And there's also, opportunities for work in this field as well, which for some people, may be of interest. So as Amanda mentioned, ECAV is the training service that provides a whole range of different training options. So it's New South Wales Health, it's an education centre against violence. So in terms of training related to sexual assault, there is an ECAV introductory course. So this is 4 1.5-hour sessions, so virtual classrooms, webinars similar to this, typically run on a Wednesday night. And there's a couple of those coming up over the second half of the year. So the next one in August, and then one again in November. So it's a great opportunity to kind of get a bit of a taste of this work and actually just develop expertise for your own practice, and they're really well run courses. Beyond that, there's a graduate certificate in the management of adult sexual assault. So it's a blended learning program, so mostly online webinars, some interactive modules, and then 2 face-to-face sessions, workshops, which are run over several days in Sydney. So one spread over in the first and second half of the year. So now the next graduate certificate is actually starting halfway through this year. I think the process was impacted by COVID, as so much was. So yeah, coming up fairly soon is the opportunity to do the graduate certificate, and applications for that are open at the moment. So they're the options relating to the training within sexual assault. Amanda, can I just get you to jump 2 slides forward? Thanks. So we have another, what I think is a really great opportunity coming up. So the PHN GP scholarships program, some of you may know about, possibly in relation to opportunities within other craft groups. So mental health, drug and alcohol, palliative care, geriatrics, mental health, I might have said that, some of the other areas that work with the PHN for these GP scholarships. So there's short-term paid scholarships, and there's some flexibility around how these run. So they're typically 40 hours spread over 5 weeks or 10 weeks, and not only provide an opportunity to learn and develop skills in an area of particular interest for you, but they're also a great networking opportunity too, and kind of allow you to have a look at some of the services within health, and for us to sort of look at those linkages and pathways, which are always so important. So look, this is something we've been working on, and we're hopeful to we're thankful to the PHN for their support, and hopeful to have in place later in the year. In terms of what that would look like, my hope is that it's quite a flexible opportunity depending on the particular interests of the GP that's applying for the role. I think there would be the opportunity to incorporate some of that ECAV learning, so particularly that introductory course could make up sort of a theoretical component of the time, allowing another 34 hours to then gain some clinical experience with the sexual assault services, but also possibly incorporating some of those other specialist areas within the violence, abuse and neglect services that may be of particular interest to you and your practice. So it's underway, a little bit of work to do, but if anyone was interested in that, I'd certainly love to hear from you and make time to have a chat with you just about that opportunity moving forward. So that's mostly from me. I was interested in asking Georgia a few questions. So amongst the many things that Georgia does, she has extensive experience working in this area. I think that's, it's remarkable the amount that she fits in, but it's also, it's really important work, and we really appreciate the contribution that she makes. So Georgia, I think you mentioned how long you've been working as a forensic examiner, but can you just remind us of that and what actually attracted you to this work in the first place? No, you're muted. We can't hear you.
Thank you. Yes, I am muted. Yes, so I've been doing on the on-call roster for 15 years, and it was the beautiful Dr. Elvira Barden that talked me into joining the roster 15 years ago. So she'd been providing medical and forensic care for many years prior to that, and she was saying what a rewarding area it was to work in. And as a GP, especially a female GP, I had all the skills required, and a bit nervous back then. And back then you mentioned all the training, like now with the ECAV and the graduate certificate. Back then it was really see one, do one, teach one. But now the service has grown so much since then, and there is, there is a lot of training and support. And look, as a GP, it's not uncommon that GPs have a special interest in one area, and it's certainly an area they'll decide to, I suppose, sort of sub-specialise into. It was good to get back into the hospital system as well. So as a GP, you get stuck in your room a lot, and it's great to go back to the hospital system where all the action is. And the other GPs and the sexual assault nurse examiners and the social workers, it's a great team to work with. So, over the years, we've had quite a number of GP examiners. We all look out for each other, support each other. It's important that we can debrief, because the cases can be quite tough as well, and there's lots of regular peer review meetings as well. So initially it was a bit daunting, but once I did a few cases and realised how supportive it was, you have a social worker with you when you do the call out. So you're never on your own, and certainly I really appreciate our peer review meetings where we get to debrief and upskill. Every case is different, but there's so many guidelines and assistance there. I think it's hard to go wrong. But so that's how I got there in the first place.
I've got some more questions for you. So are there any challenges, or what are the challenges that you face in doing this sort of work?
I suppose, signing up to doing after hours when you think you've done with your resident years and your registrar years and no more on call. I somehow signed myself to do on call again. But look, yes, once you get to the hospital though, you actually, you've got that vulnerable patient there. You can see you make a difference by validating what they've been through and offering that service. It makes, those 2 a.m. call outs all worthwhile. And plus the more doctors we've got on the roster, hence we're speaking to you all tonight, the less on call you have to do. So I do 1 weeknight of on call a week, and then 1 in 4 or 5 weekends. And you don't get called that often, so it might be a handful of times a year. I'm actually on call tonight, so let's hope I don't get called. But, so and the other challenging thing, I suppose, every case is different. So I've been doing for 15 years. I've probably done, I don't know how many forensics over the years, 60, 70 forensic examinations, and every case is different. And sometimes you're second guessing yourself in the middle of the night that you've done the right thing. But at the end of the day, we're there to support the patients. Not all the cases go to court, but certainly, there's a lot of guidelines to go through, so it's hard to go wrong from that point of view.
Yeah. Well, thank you. I think you've answered my final question, was what keeps you in the work despite the challenges? I think you've...
Yeah, so I suppose, yeah, working as a team, you're at the end of the day, even though it's obviously horrible what's happened to the patient that you've seen, at the end of the day, they walk out feeling validated and a bit better than what they felt before they entered the service. I think the ongoing education and support, like we're always learning, there's lots of training available, yeah, it's great to be able to continue to upskill in that area. Not only is it doing the forensics, it's the STI, it's the toxicology, it's the medical care, the psychosocial care, report writing. Yes, we do have to attend court sometimes, but yeah, and I suppose we didn't mention it's all very CSI as well. You get to where you forensic when you do it. So yeah, it's a nice little special interest. The other thing too, with the team is the teamwork and the debriefing as well amongst the team is really good. So if we get a tricky case, we can either discuss it at our next meeting, or I'm lucky at our practice, I've got another doctor at our practice that also works in the service, so we can often have a little cup of tea and debrief if need be. So it's very, very well supported.
Excellent. Did you have anything that you'd like to add with regards to that, Amanda, around the nature of the work and the positives about it?
Yeah, that I absolutely enjoy the work myself, and I do some of the on-call work as well. I think it's just an area, it's a bit of a niche area that you can get into and stay into, which I think Georgia is a testament to that, of being in the area for 15 years. I'm only hitting 9 years, so we'll see how we go, but I enjoy the work. I enjoy working with the clients and the patrons of the service, and I guess at the end of the day, you're making a difference, which is why you'll become a GP, is to make a difference and to help people in their journeys of life. So
excellent, thank you. Over to you, Georgia.
Okay, so I'm just seeing if there's any questions in the chat box, but and Mel will let me know if there's some that I can't see. But I suppose a question would be, I don't know if you want to go through it, Amanda, is I suppose to talk to the GPs, I suppose walk through what we do in an actual forensic examination. So so when they present to hospital, just walk through what actually sort of happens from the taking the history point of view and doing the forensic. Did you want to talk through that at all?
I sure can. Yeah, so basically, so you've seen from the first part what happens is that person is referred to the ED, likely by yourselves if it's in that GP setting, and they present to the Gosford triage and they advise that they've been sexually assaulted. No other information is handed over of that time. Our staff in the ED are trained and aware that all they need to know is that they've been sexually assaulted. They ask the patient if they will consent for the sexual assault service to get involved. And then from there, the nursing unit manager of the ED contacts the social worker if it's on call or during the day. And the social worker is the first person that responds to the patient in the ED. And then that psychosocial assessment is attended. So in that, they're gaining that information of who they are, the type of assault that has occurred, and requesting, to the patient if they want a medical or a medical forensic response. So all those things are offered to the patient. And it's at that first point of call that we are trying to empower the patient to, make choices for themselves and to offer services that they have the choice to decline or accept. And so once the social worker has attended their psychosocial assessment, including their well-being and safety concerns, especially if there's any children in the home or if there's children involved, they're making those mandatory reports, just like yourselves out in the community in your GP practices. And then they will contact the sexual assault examiner and it's absolute policy. So when they present to the ED, that they provide their psychosocial response, that a medical consultation occurs with a forensic examiner for every sexual assault presentation. And then it is the medical forensic examiner that goes through the type of assault and if they're in time frame or not. So when we spoke about that, you know, within that 7-day time frame, the medical forensic examiner would respond if it was after hours, and if it's at 7 to 14 days, it might be a daytime presentation. So the psychosocial assessment's attended, the safety concerns are addressed, and then that patient can be discharged home with follow-up with the service the next day. If they're within a medical forensic time frame and they're requesting a forensic response, we have a special room down in the ED, which is our forensic suite, that is well cleaned and is only used by the sexual assault service, and that's where all of our medical forensic examinations occur. And we'll take that patient down with the social worker into the forensic suite, which is just off the ED. And then from there, we are guided by the medical forensic examination record, which basically starts from who the patient is that's sitting in front of us, and then goes right through to the date that the assault occurred, the type of assault that had occurred, and we write a direct narrative of when we ask them, you know, that they're presented to the ED, you know, can you tell me what happened? And from there, we'll write that narrative down. That narrative then guides our medical forensic response in terms of what type of swabs we're going to collect, if we're going to collect slides. And then from there, also the medical examination, where we're examining the patient from top to toe. So if they talk about strangulation, then we'll do a strangulation assessment. If they're saying, you know, they fell down and hit their knee, we'll explicitly be looking at the knee. And then from there, we write all of the injuries of that top to toe assessment also in that medical forensic examination record. If the patient discloses that there was drugs or alcohol involved that were consumed at a voluntary or involuntary nature, is we record that information down as well, and we offer the patient the opportunity of a toxicology, that is a blood and a urine sample that contributes to that sexual assault investigative kit. And then after that, we send the patient on. So we look at our medical examination in terms of STI screening, emergency contraception, hepatitis B vaccination, and we'll make an appointment to follow up either with the VAN outpatients department, and again, that's a service that we offer. The patient may opt to attend their GP, which would be yourselves back out in the community. And then we also offer that warm referral handover, and we gain their consent to contact the GP and advise the GP of what has occurred, and then send through a letter of the information of what we attended in the ED, which is basically what medication we gave, with the type of assault that has occurred, and the recommended follow-up for the patient. So if they've received PEP, or they're following up with a sexual health clinic, if they, require further hepatitis B vaccinations, we'll put all of that in a letter to yourselves and send that through. And then from there, we give the patient back to the social worker in terms of handing the patient over, and then the social worker will take them back out into the, we call them family rooms in the ED, and then that's where we as examiners bag all of the evidence up. When it gets to the point of closing the envelope up, we invite that social worker back into the room. We explicitly do not leave the room until all of that is wrapped up and sealed, and then we place it in the fridge. And based off the information that the client has given us in terms of their options, if they want an immediate response where they release their sexual assault investigative kit, also known as a SAKE kit, to police, is we will contact police and advise them of that, generally during business hours, so that they can come and collect at the same time. or if they want a delayed response. So there's actually no police involvement and they're not obligated to contact police. And we hold that sexual assault investigative kit for a period of 3 months. And then in which case we contact the client and then ask them what it is that they're wanting to do with their sexual assault investigative kit. If they're, wanting to pursue the matter, if they're absolutely adamant they're not wanting to go through with it, we gain their consent to destroy the sexual assault investigative kit. And that's one of the things that we go through at the time of the medical forensic examination record, is what they want to do with that information. And they're aware that after 3 months, if for whatever reason they move house or change their phone number, that after the 3-month period that the sexual assault service will destroy that sexual assault kit.
Very good. And the other reassuring thing, Amanda, is patients are medically cleared before they do see us, because obviously there's someone that's strangled or has got a rib fracture or a facial fracture, or you worry there you've got the backup of the emergency department as well. So patients are generally stable before we take them out to the forensic room, or if during the medical examination we find that the patient might have more significant injuries, we often either, depending on what the type of injuries, it might be discussing with the emergency doctor or calling the gynaecologist in to review the patient. So so you do have the full medical backup. It's not like they get put to sexual assault and that's it, you're on your own. You do have the backup of the emergency department as well if there are other injuries that do need to be followed up. And certainly over the years we've had to really push on the strangulation case a bit, haven't we, Amanda?
Absolutely.
Yeah, because previously it wasn't thought to be as serious, but now there's obviously emerging evidence that yes, it needs to be taken seriously. It's a risk factor for future, mortality for patients, or for those that do assailants that do strangle. There's a high mortality rate in the future, so it's something that needs to be taken seriously as well. And just another question. So in terms of the number of presentations on the Central Coast, so how many presentations would there be, and what's the percentage of total assaults? Because obviously not everyone that's assaulted presents, unfortunately. So have you got any stats on the number of presentations sort of per year that we receive with our service? And are we seeing just the little tip of the iceberg?
Yeah, I don't know. Vicky, would you have any stats on hand?
Yeah, look, I think, the short answer is that we see the absolute tip of the iceberg. In terms of patients presenting to emergency, I think you're far more likely to be seeing patients who've been sexually assaulted on a day-to-day basis in your practices, and that's something that they may not tell you, and they may not tell anybody. I think in terms of people assaulted, it's probably only half that actually share that, and it's often with family or friends. I think 40% will end up telling a health professional. So definitely the tip of the iceberg. In terms of numbers, we see an average of 1, maybe 2 assaults per week, and it does change a bit over time. So we have looked at the stats in terms of whether they present during the day or after hours. I think at the moment they're very much presenting after hours, but that certainly has not always been the trend, so it is a bit variable. We definitely saw a dip in presentations throughout COVID. I don't know if that was people being reluctant to present to hospital at all, and again we're having, I should touch wood because you're on call, Georgia, but we're having another quietish period as well. So yeah, it's not a huge volume of patients, but as Georgia and Amanda have illustrated, they're varied. It brings together all of your different skills. My other role is working in drug and alcohol, and Amanda's currently working in mental health, and so the crossover of patients is enormous. So yeah, I think that answers the numbers. And I guess a comment I would make about the point you made, Georgia, about the kind of that team approach to providing care. The forensic medical or the forensic suite is co-located in the emergency department, so it's it's physically very easy to seek other support. Taking the patient back into the acute part of the emergency department, or having the patient reviewed by mental health or drug and alcohol or whoever else it may be that needs to get involved in the patient's care.
Very good. I'll just see if there's any more questions there.
And I could just, the last slide is just, for whatever reason, if that patient decides that they're not wanting to take up a service with a sexual assault service or present to ED, and they're sitting there in your GP room asking for support, there's some useful contact support. So obviously they can contact the sexual assault service of their local area, and for the Central Coast it is Gosford, but there's also a wide variety of other services available as well.
Yeah. And I think there's a lot of information on health pathways as well. There is information about sexual assault services with a lot of these contacts as well. So on health pathways, I think that came out last year. Is that right, Amanda?
Mm-hmm.
Yeah. So all that information will be there as well.
Amanda, can you just mention the online reporting? Because I think that's something that most people aren't aware of in terms of, if someone wants to anonymously report a sexual assault.
Yeah, absolutely. And it was, you must have read my mind, Vicky, because it was on my mind to mention at the end. So there is a online reporting option, and it's called SARO, which is the Sexual Assault Report Online. And so they basically put into Google SARO and it will come up. And what it is, it allows them the opportunity to report the sexual assault in the computer system, which is directly related to police, and they can do that with all of their contact details, but they can also do it anonymously as well. In terms of if the crime was, quite a vicious attack, and they don't want it to happen to other people, but at the same time, they're not ready to come forward themselves, is they can report the incident, the time and the date, and as much information about the perpetrator as possible. And all of that goes directly to police, where they can do their own investigations that doesn't involve the person as well.
Yeah.
And what's the direct number to call the sexual assault services? Would that just be ringing switch, or is there a direct number that GPs can call?
So the direct number for the sexual assault service, I'm just saying, I don't think it's actually on there, is that 43203175, which is, people may know the service as Biala. So Biala, has recently changed names to the sexual assault service. And you can also, the New South Wales Health website, which is your, in those useful contacts, the sexual assault services contact in your local hospital, has a list of all the sexual assault services throughout New South Wales, including the Biala/Gosford Sexual Assault Service.
Good. So hopefully there's some GPs out there interested to join our service. We'd love to see more of you. So happy to contact Vicky, but I'm also happy to chat from the GP perspective as well. So because it is a really rewarding service, and Amanda and Vicky do a fabulous job as well, and as well as the other GPs that we have on the roster at the moment that have been doing sexual assault on call for just as long as I have. Without them, the service wouldn't be possible. And hopefully we've, I suppose, dispelled some of the myths. Like when a patient does present in general practice, it can be, often it's a 15-minute appointment and we're like, what do we do? But hopefully this is linked in a lot of the services available, and you can make a head start as well. Depending on if they want to present to a hospital or they may not want to, what we can offer in terms of STIs and contraception and hepatitis B vaccination. So I think you were saying, Vicky, that only 25% of people actually get a response to their Hep B immunisation. So if in doubt, it's worthwhile doing a booster if they have been exposed.
Yeah, like I think there's emerging evidence that that childhood vaccination is maybe not affording you know, as much protection as it could, especially in these vulnerable populations. And there's also evidence that if we do in a timely way give a Hep B vaccination after an acute event or an acute exposure, that can be helpful. So I think there's more to see in this area moving forward, but we've certainly been in conversation with the public health unit and you know, trying to have Hep B vaccination in the forefront of our minds. I think another valuable thing that we do through the outpatient clinic, and again, we're working in partnership with the public health unit here, is that we're really, you know, many of the patients that we see are very vulnerable. You know, they probably weren't at school, you know, a lot of the time in the, you know, where they may have been accessing, or where, you know, they possibly were offered or could have been offered other vaccinations. So we're seeing a cohort that you know, aren't accessing healthcare, and so we're trying to do what we can in terms of catch up with their immunisation schedule and all sorts of other things in terms of their healthcare. So we would love them to be seeing a GP regularly. That doesn't always happen for a range of reasons, and I guess our hope, even in their kind of acute presentation to the hospital, is if we can provide them with care that's compassionate and acceptable to them, and you know, break down some barriers, then it probably encourages some future help and health-seeking behaviours, which I think are really important. One of the things we really look at with the patients in the outpatient clinic is, you know, having a chat about contraception, and it's quite remarkable the number of patients that we're seeing who aren't accessing contraception, and so therefore at risk of unintended pregnancy, and you know, and they're a group that you know, often that's not going to be a good option for them or their child moving forward. So trying to make services available to them and acceptable is really a priority of the care that we provide.
Very, very true. It's not just about their sexual assault presentation. It's while they're there taking the opportunity to look at them with that preventative health approach as well. And certainly a lot of these patients wouldn't be seeking health care otherwise. So while they're there, we do as much as we can to keep them engaged, and certainly with the work that Vicky and Amanda have been doing with the new outpatient clinic is definitely helpful in that regard. So yeah. Any final questions or closing remarks, Vicky and Amanda?
Nothing from me.
Yep.
I'll jump in with the closing remarks. So I'm really happy. I haven't included my email anywhere, but I will share that. So I guess if there's any questions about the sexual assault service, but more broadly about van services, or any interest in, you know, even a chat or coming to have a look around at what we do, I'd certainly be happy to speak to anybody. And yeah, just bear in mind the opportunity for the scholarships, hopefully by, you know, a little bit later in the year. And as I said, we're really keen to tailor it to kind of meet your needs and the nature of your practice and what might be helpful. So keep all that in mind, and certainly shoot me an email with any questions.
And you mentioned the courses. That ECAV course is a no obligation course that you can do just to see if it's something that you're interested in as well. So it's 4 weeks, 1.5 hours. So you can, and it doesn't cost anything. So the Education Centre Against Violence. So that might be something just to spark your interest, or as you mentioned before, doing the scholarship program where that can be included as part of that. And those, I think those courses are going to be put up on the PHN website as well. Is that right, Melissa?
Yeah, I was just thinking that might be a great resource to have on the website, so I might ask you to please send those through, and in the education library as well, along with the copy of the recording and the presentation, so that anyone that's interested can easily access those. I think that'd be really good.
Yeah, it's fantastic training through ECAV. I'm, you know, have worked in other areas and moved to this more recently, and you know, certainly in terms of training and support, it's really quite remarkable, well put together, and really useful. So I would strongly recommend people have a look at that. And the introductory course, yeah, great learning for, you know, even if this isn't an area that you want to step into. I think it's great to have that that knowledge and understanding just for your day-to-day work. So definitely recommend it.
Thank you so much, and thank you so much, Georgia, for facilitating tonight, and to Vicky and Amanda for being here and the amazing work that you do. We all appreciate it. Is there anything else that anyone would like to add before we close off? Or if any questions are coming through, pop them in the questions box now, or if you think of one after, send them through to education@thephn.com.au. All right, I think we've covered it all. So thank you so much for being here. It was such an important topic. A copy of this will be available in the Education Library along with the presentation as well. And also please remember that the survey will pop up as soon as the webinar is completed. So I strongly encourage you to please complete that as well. Thank you, everybody. Thank you for being here. Have a lovely evening.
Thanks.
Good night. Bye.
I don't know how to hang up.
Oh, I'm trying to read it.
Oh God, I've never been on this platform before.
I think we just
I don't know if we've stopped recording. Let's.
Well, you're wise. You're off your camera. That'd be a good start.
Am I off the camera? Am I? Yeah, I think I've got to hang up there. But I'll, yeah, I'll give you a buzz anyway. I'll hang up and give you a buzz.
Yeah.
Paused.
Turn the computer off.
Bye, guys.
How do I leave? Oh, here we are.